Welcome back to another edition of The Deep Dive. Today we are doing something a little bit different.
A little bit.
Usually we take an article or maybe a news story and we break it down, but today we are tackling a heavy hitter. I mean, in the world of medicine, there are textbooks and then there are, well, institutions.
Oh, yeah.
Today we are figuratively and literally heaving the Bible of surgery onto the desk.
Baily and Love. Just hearing the name brings back memories of late-night library sessions for almost every surgeon I know.
Specifically, we are looking at the Short Practice of Surgery, the 28th edition. Now, looking at this thing, short feels like a bit of an ironic title.
Just a bit, yeah.
It's massive. It's comprehensive. And for a medical student, I imagine it can be absolutely terrifying.
It can.
But we aren't trying to read the whole thing today. We are zooming in with laser focus on one specific chapter, Chapter 47, Plastic and Reconstructive Surgery.
And honestly, this is the perfect chapter to deep dive into because it is one of the most misunderstood areas of surgery.
Right.
Oh, definitely. It's also one of the most conceptually difficult chapters for students because it shifts the way you have to think about the human body.
Right, because when you say plastic surgery to the average person on the street, or even a first-year med student, what do they think?
Hollywood?
They think Hollywood. They think facelifts, nose jobs, vanity projects.
Exactly. They think purely aesthetic. But Chapter 47 clarifies immediately that this is a misconception. I mean, if you look at the other chapters in Baily and Love, they are defined by a specific organ system.
Sure.
If you're a cardiac surgeon, you operate on the heart. If you're a neurosurgeon, you operate on the brain. If you're a hepatobiliary surgeon, you own the liver. They have their turf.
But plastic surgery doesn't have a turf.
No turf. Plastic surgery is defined by a concept. It is a problem-solving specialty that applies to the entire body, from, the top of the scalp to the tip of the toe.
And that concept is the mission statement of this entire deep dive.
It is.
Form and function.
Precisely. The text tells us the word comes from the Greek plasein, which means to mold or to shape. It is about restoring the body after trauma, cancer, infection, or congenital defects. It's about making a person whole again, not just making them look younger. It's about restoring the form, what it looks like, and the function, how it works.
So before we get into the nitty-gritty, and we're going to talk about flaps, grafts, and the power grid of the skin, I want to set the ground rules.
Good idea.
This deep dive is an interpretation. Think of it as a ready reckoner. If you are a medical student listening to this, do not throw away your textbook.
Please don't.
We are building the mental scaffolding so that when you do sit down to read Chapter 47, the information has somewhere to stick.
Think of this as your roadmap through the territory. We're going to hit the landmarks, the history, the anatomy, how wounds heal, and why they sometimes don't.
And then the heavy machinery.
And then the heavy machinery, the reconstructive ladder, or rather, the elevator.
I love that elevator concept, and we will get there. But first, let's look backward. Because reading this chapter, I was surprised to find that while plastic surgery feels very modern, lasers, microsurgery, robots, it's actually ancient.
It is ancient. It's not a 20th century invention. The text takes us all the way back to 600 BCE in India. There was a surgeon named Sushruta.
600 BCE. That is just mind-blowing.
It is. And he wasn't just stitching up cuts. Sushruta described facial flaps. He had a method for repairing split earlobes and, most famously, a technique for nasal reconstruction using a forehead flap.
Why? Why were they reconstructing noses in 600 BCE?
Well, often the nose was cut off as a punishment for crimes or adultery, so there was a high demand for reconstruction to restore social standing.
Wow.
Sushruta figured out that you could take skin from the forehead, flip it down, and make a new nose. That technique is actually still used today in some variations. That's nearly 400 years before the Western world really caught up.
That is incredible. But the text mentions that the modern era, the real founding fathers moment, for the specialty as we know it, happened during the First World War.
It was a necessity. You have to remember, WWI was the first industrial war, trench warfare, high explosive shells. It caused, devastating facial injuries that had never been seen before.
Right.
You had soldiers surviving injuries that would have killed them in previous wars, thanks to better evacuation, but they were left with significant disfigurement. Their jaws were gone, their noses were gone.
And that's where Sir Harold Gillies comes in, right?
Yes. Sir Harold Gillies. He was a New Zealand otolaryngologist working in London, and he is considered the father of modern plastic surgery. He set up a unit specifically to treat these soldiers. He developed techniques to rebuild faces, not just for looks, but so these men could eat, speak, and function.
Again, Form and function. It wasn't about vanity. It was about giving them their lives back.
Exactly.
So that's where we came from. Now let's talk about the canvas these surgeons work on, the skin.
The largest organ in the body.
The text does a quick review of the layers epidermis on top for protection, dermis in the middle providing the structure and housing the vessels and nerves, and the hypodermis or subcutaneous fat at the bottom. But the real game changer in this chapter, the concept that I really struggled to wrap my head around at first, is the angiosome.
This is crucial. If you take one thing away from the anatomy section, let it be the angiosome. This was a concept introduced by Taylor. It completely revolutionized how we move tissue.
Okay, let's unpack this, because when I read it, I tried to visualize it, and I got a bit lost. It describes it as a composite block. How do you explain an angiosome to someone who isn't looking at a diagram?
It's tricky. Let's strip it back. Forget the skin for a second. Think about a city. Or, better yet, think about your house. You have the siding, the insulation, the drywall, the studs.
Okay, I'm with you. Layers of the house.
Now imagine that for every room in your house, there's exactly one main power cable running from the street that turns on the lights in only that room.
So the kitchen has a dedicated cable. The bedroom has a dedicated cable.
Right. That room, including the walls, the furniture, the lights, is an angiosome. It's a 3D block of territory supplied by a single source.
Oh, okay.
In the body, that source is an artery. So an angiosome isn't just a patch of skin. It's the skin, the fat under it, the fascia, the muscle, and even the bone deep down, all fed by that one power cable.
That makes so much sense. So the body is basically a 3D map of these power grids.
Exactly. And here's why Taylor's discovery was so radical. Before we knew this, surgeons were just cutting rooms out of the body at random to move them.
Just guessing.
They were cutting patches of skin and hoping they would survive. And guess what happened?
The lights went out. The tissue died.
Exactly. Because they unknowingly cut the power cord. Taylor mapped the entire human body and said, here are the territories, here are the blocks, and here's exactly where the power cable enters for each one.
So if you know where the neighborhood boundaries are, and you know where the power line is, you can detach that entire neighborhood, that angiosome, from the underlying bedrock, move it somewhere else, and as long as you keep that power line connected, the neighborhood survives.
That is a perfect metaphor. That is the basis of the flap surgery we are going to talk about later. You can't just cut a piece of meat and move it. You have to know its power supply.
Right.
The text mentions that these source vessels send perforator, little branches up through the muscle and fascia to the skin. It's all about blood supply. Without blood, tissue dies. It's that simple.
Okay, I want to do a quick check-in here for you listening. This is a foundational concept. Pause for a second. Can you define an angiosome in your own words? If you can't, rewind 60 seconds. It's a 3D block of tissue supplied by a specific source artery. Got it. Okay, let's keep moving.
Let's talk about what happens when that canvas is damaged. Wound healing.
The chapter breaks this down into primary and secondary healing. This seems pretty straightforward, but there is some nuance here.
Primary intention is what surgeons aim for. You have a clean cut, you bring the edges together with sutures, staples, or glue, and it heals. Ideally, you want to place those incisions along what are called relaxed skin tension lines, or RSTLs.
RSTL. These are the natural crease lines of the skin, right? Like the wrinkles on your forehead when you raise your eyebrows.
Yes. Think of the grain in wood. If you cut parallel to those lines, the scar hides in the wrinkle. There is less tension pulling the wound apart.
And if you cut across them?
If you cut across them, perpendicular to the wrinkles, the muscles underneath are constantly pulling the wound open every time you move. That tension leads to a wide, ugly scar.
Then there is secondary intention. That sounds like the lazy way, just leaving it open. But the text says sometimes it's the only way.
It's not lazy, it's strategic. Imagine you have a dirty, infected wound or a massive ulcer from a dog bite. If you stitch that shut immediately, what happens?
You trap all the bacteria inside. You create an abscess.
Exactly. So you leave it open, you let the body do the work. The body fills the hole with granulation tissue.
Granulation tissue. That's that beefy, red, bumpy tissue you see at the bottom of a healing scrape.
Correct. It's rich in blood vessels. It fills the defect from the bottom up, and then the skin cells slowly migrate in from the edges to close the roof. It takes longer, and the scar might not look as pretty, but it's safer for certain wounds.
But healing doesn't always go to plan, and this is where we get into the aberrant healing section. This is a classic exam topic, and I bet every medical student listening has been grilled on this. Hypertrophic scars versus keloids.
Oh, yeah.
To the untrained eye, they both just look like big, red, lumpy scars. What is the actual difference?
It comes down to boundaries. That is the key word. A hypertrophic scar is raised and red. Yes, it can be itchy, but it stays within the boundaries of the original injury.
Okay.
If you cut your arm in a straight line, a hypertrophic scar stays on that straight line. It might be thick, but it doesn't spread sideways. And importantly, they often improve spontaneously over time.
And a keloid.
A keloid is a rebel. It doesn't respect boundaries. It grows beyond the limits of the original wound. You might have a tiny ear piercing, but you end up with a growth the size of a grape hanging off the lobe. It invades the surrounding healthy tissue. It acts almost like a benign tumor.
The text mentions that darker skin types are more prone to keloids, and they're notoriously hard to treat.
Very hard. If you just cut a keloid out, the body reacts to the new injury by making even more scar tissue. It often comes back bigger. You usually need a combination of surgery and radiotherapy or steroid injections to stop it.
Now, there's one more bad guy in the wound healing section that the text flags up. I call it the tiger in the grass because it looks like a chronic wound, but it's actually something much worse.
The margolin ulcer.
The margolin ulcer.
This is a critical red flag. A margolin ulcer is a squamous cell carcinoma, a type of skin cancer that arises in a chronic wound. Think of a patient with an old burn scar from 20 years ago or a pressure sore that just won't heal.
And it suddenly changes.
Suddenly, the character of the wound changes. It gets lumpy or bleeds or the edges roll up.
And the takeaway here is biopsy it.
Always. If a chronic wound changes appearance or fails to heal after a long time, you have to rule out malignancy. Don't just keep putting dressing on it.
Speaking of dressings, let's talk about how we help these wounds heal. The text lists a bunch of brand names: Gelinet, Alavin, Aquacel. It feels like walking down the aisle of a pharmacy and getting overwhelmed. How do we simplify this?
You match the dressing to the wound. It's all about moisture balance. You don't want a wound to be a desert, and you don't want it to be a swamp.
Right.
If the wound is clean and dry, like a simple scrape, you want something that won't stick and rip the new cells off when you change it. That's Gelinet. It's basically gauze soaked in paraffin wax.
So it's greasy.
It's greasy. It soothes and protects.
Okay, so dry wound gets the greasy dressing.
Right. Now, if the wound is wet, if it's oozing lots of fluid, which we call exudate, you can't put grease on it. It would get soggy. You need a sponge. That's Alavin or foam dressings. Or Aquacel, which turns into a gel when it gets wet.
They just soak it up.
They soak up the mess and keep the wound edges healthy.
And then there's the vacuum, the VAC.
Negative pressure wound therapy. This is the heavy artillery. You put a sponge into a deep cavity, seal it with an airtight film, and hook it up to a suction pump.
What does the suction actually do? I mean, it seems so aggressive.
It does three things. One, it sucks out the excess fluid so bacteria can't breed. Two, it physically pulls the edges of the wound together, shrinking the hole.
Oh, wow.
And three, that negative pressure stimulates blood flow, which makes that beefy red granulation tissue grow much faster. It's fantastic for complex, gaping wounds.
All right, I want to try a case study here to solidify the scarring concepts we just talked about.
Let's do it.
Imagine a patient walks in. He had open heart surgery 3 months ago. He has a scar down the center of his chest. He complains it's itchy, it's thick, and it looks like it's spilling over the edges of the original incision line, almost like a crab with legs extending into the normal skin.
Mm-hmm.
Is this a hypertrophic scar or a keloid?
The key clue there is spilling over the edges. And the location, the chest is a very common site for this. That sounds like a keloid.
Not hypertrophic.
A hypertrophic scar would be thick, but it would stay strictly on the incision line. That crab with legs description is classic keloid.
Spot on. Okay, let's move to the toolbox. The reconstructive techniques. This is the core of the chapter. The text mentions a reconstructive ladder, but then says it's becoming obsolete. Now we use an elevator.
Right. The ladder was the old way of teaching. It implied you always start at the bottom, simple stitching, and only move up to grafts or flaps if the simple stuff fails.
So you had to feel your way up.
It made surgeons hesitant to do the complex stuff. The elevator concept means you go straight to the floor that gives the best result for the patient. If the best result is a complex flap, you take the elevator straight to the top floor. You don't waste time and suffering on the lower levels.
I like that. Efficiency.
Yeah.
So let's talk about the two main tools in this elevator, grafts and flaps. This distinction is the most important concept in the entire chapter. What is the fundamental non-negotiable difference between a graft and a flap?
It's all about the blood supply. A graft is tissue moved without its blood supply. You cut it completely free. It's like a seed.
Yeah.
A flap is tissue moved with its blood supply. It remains attached to its power cord, or we reconnect it. It brings its own food and water.
That distinction changes everything. Because if a graft is like a seed, or maybe a parasite's a better word, it needs something to live off of.
That's a great way to put it. And to understand the risk, you have to understand the biology of survival. When you cut a skin graft, let's say a full thickness graft from behind the ear, you have completely severed it from the body. It is 100% dead meat the moment it hits the instrument tray.
That's a grim image. So how does it come back to life?
It has to attach to the wound bed. For the first 48 hours, it literally drinks. It soaks up plasma from the raw wound like a sponge. This is called plasmatic imbibition.
Imbibition, like imbibing a drink.
Exactly. But a sponge can't live forever on plasma. It needs real blood. So around day 3 or 4, the blood vessels from the wound bed actually start to grow up into the graft and connect with the graft's old, empty vessels. That's called inosculation.
Inosculation, which means kissing, right?
Yes, kissing vessels. Now, this explains the golden rule of grafting. If I put that sponge on a piece of bare metal titanium or bare cortical bone...
Metal doesn't sweat plasma. Metal doesn't grow blood vessels. The parasite starves.
The graft dies. That is why you must have a vascular bed for a graft. It needs a healthy, bleeding base. You cannot graft on bare bone, bare tendon, or hardware.
Okay, that is crystal clear. So let's dig into the types of skin grafts. The text divides them into split thickness and full thickness. Or, if you want the old school names, Tiersch and Wolf.
Right. A split thickness Tiersch graft takes the epidermis and just a sliver of the dermis. A full thickness Wolf graft takes the epidermis and the entire dermis.
I need an anchor here. How do I remember the difference in how they act and when to use them?
Think of a split thickness graft like turf. You shave it off the donor site, usually the thigh. It's thin, it's flimsy. You can mesh it, poke holes in it to stretch it over a huge area, like a massive burn.
Okay.
But like turf, it doesn't look perfect. It tends to shrink or contract as it heals. It's functional, not pretty.
Okay, so split equals turf. Good for big muddy fields, big burns.
Exactly. Now think of a full thickness wolf graft like a high quality Persian rug.
I like this.
It's thick, it's durable, and it looks good. It doesn't shrink much because it has that thick dermis holding its shape. But you can't get a Persian rug the size of a football field.
Yeah.
You can only take small pieces from behind the ear or the groin because you have to stitch the donor site closed.
So if I have a small defect on the face where looks matter, I want the Persian rug. I want the wolf graft.
Yes. But if you have a massive burn on the leg, you need the turf. You need the split thickness.
Okay, check-in question for you listening. You have a patient with a large burn covering their entire thigh. Do you use a wolf graft or a Tiersch graft?
You'd use a Tiersch, the split thickness graft. You need coverage, and you don't have enough spare skin to do a full thickness graft for an area that big. Plus, the thigh doesn't need to look as perfect as the face.
Okay, we've covered grafts, the seeds, the parasites. Now let's bring in the heavy machinery, the flaps.
Right.
You said a flap brings its own blood supply. This allows us to cover things that grafts can't, like that exposed bone or metal plate we mentioned.
Correct. If you have an open fracture with the bone sticking out, a graft will fail. You need a flap. You need to bring a thick blanket of live tissue with its own heater, its own blood supply, to cover that bone.
The text introduces the 5 C's to classify flaps: circulation, composition, contiguity, contour, and conditioning. It's a nice mnemonic, but the one that really trips people up and the one that fills pages in the textbook is the classification by blood supply. This seems to be the part where students glaze over.
This is the hard part, but let's simplify it. We essentially have 2 main categories of tissue we use for flaps: skin with fascia and muscle. For fasciocutaneous flaps, that's skin plus fascia, we use the Cormack and Lamberty classification.
Okay.
For muscle flaps, we use Mattheys and Nahai.
Okay, let's break down Cormack and Lamberty first. The skin flaps, types A, B, and C. How do we distinguish them?
Type A is simple. It's supplied by multiple little vessels coming up from the bottom. Think of grass roots. Type B is a single big vessel. The text mentions the scapular flap. It's like a tree trunk feeding the flap.
And type C.
Type C is the interesting one. It has segmental perforators along the length of the flap. The classic example is the radial forearm flap, often called the Chinese flap because it was popularized in China. It runs off the radial artery.
Okay, so type A is many small, type B is one big, type C is segmental, like the radial artery.
You got it.
Now let's tackle the muscle flaps, Mattheys and Nahai. This is the exam favorite. There are 5 types. How do we anchor these so we never forget them?
Let's look at the logic of the anatomy. Type I. One dominant pedicle, one big artery feeds the whole muscle. The example is the gastrocnemius, the calf muscle,
Okay.
or the tensor fascia lata, the anchor. Think gas 1 meus, type 1.
Yes, well, yes, I like that. What about type 2?
Type 2 has one dominant pedicle plus some minor ones.
Yeah.
The gracilis muscle is the classic type 2. Ideally, you want to use the dominant one, but it has backups.
Type 3.
Type 3 has two dominant pedicles. It's greedy. The rectus abdominis, your six-pack muscle, is a type 3. It gets blood from the top, the superior epigastric, and the bottom, the inferior epigastric.
So you can flip it either way.
This is why you can flip the muscle up to reconstruct the chest or down to reconstruct the groin. It has a supply at both ends.
That's versatile. Okay, skip type A for a second, because type V is the big one we see all the time.
Type V. One dominant pedicle plus a bunch of secondary segmental ones. The latissimus dorsi is the poster child for type V.
And the anchor for that one.
The latissimus is the biggest muscle in the back. It's huge and needs a high number, type V.
So latissimus equals large equals type V, gastrocnemius, gas-1-nemius, type 1, rectus abdominis, two ends, type 3. See, that's manageable.
It is when you break it down.
Now let's apply this elevator concept to a real nightmare scenario. You're in the ER, a patient comes in, 25 years old, motorcycle crash. He's got a massive open wound on his shin. The skin is gone, the muscle is torn, and I'm looking at bare white tibia bone. The orthopedic surgeons have fixed the bone with metal plates, but now you have metal and bone staring at you.
Okay, let's get in the elevator. Ground floor, primary intention. Can you just stitch it shut?
No way. The gap is too wide, the skin is gone.
First floor, secondary intention. Can we just leave it to heal?
I don't think so.
Okay.
Bone is exposed. If we leave it, the bone will dry out and get infected. We call that osteomyelitis.
Correct. Second floor, skin graft. Can we put a piece of turf on it?
We just talked about this. It's bare bone and metal.
Yeah.
No blood supply, no plasma to drink. The graft would die.
So the elevator keeps going up. We are now in the penthouse suite, the flap. We need to borrow tissue that brings its own heater, its own blood supply, and drape it over that cold bone.
What are our options?
Well, we could use a local muscle flap like that type I gastrocnemius we talked about. Since it has one big vessel at the top, we can detach the bottom, swing it over the bone like a trapdoor, and suddenly that bone is covered in warm vascular beef.
And then put a graft on top of the muscle.
Then we put a skin graft on top of the muscle. Problem solved.
And if the hole is too big for the calf muscle?
Then we do a free flap. We take a chunk of tissue from the thigh or the back, like the latissimus, disconnect it completely, limit to the leg, and use a microscope to sew the tiny arteries and veins of the flap to the arteries and veins in the leg.
You're plumbing it in.
It's like plumbing in a new appliance.
That brings us nicely to the final segment. Innovation. Plastic surgery is tech-heavy. We just mentioned microsurgery sewing vessels smaller than 1 millimeter. That allows for replantation, right? Like sewing a severed finger back on.
Exactly. But there are other innovations in the text that are really clever. Tissue expansion is a fascinating one.
This one makes sense intuitively. It relies on the biological principle of pregnancy.
That's exactly it. Pregnancy stretches the abdominal skin over 9 months. Tissue expansion replicates that. We place a silicone balloon under the skin near the defect. Over weeks, you inject saline into the balloon. The skin stretches a process called creep and stress relaxation. You literally grow extra skin.
And they use this for breast reconstruction or even fixing bald spots.
Yes. If you have a burn on the scalp with no hair, you can expand the hair-bearing skin next to it and then stretch that hair-bearing skin over the bald spot. You are essentially creating new skin.
Then there's lipotransfer. Fat grafting.
This was popularized by Coleman. You suck fat out of the belly or thigh liposuction, spin it in a centrifuge to get the pure fat cells, and inject it somewhere else.
For cosmetic reasons.
It's used for cosmetic reasons, plumping lips or cheeks, but also reconstructive. It improves scar quality, it brings in stem cells.
But there's a catch, right? It sounds too good to be true.
The catch is resorption. The body tends to, eat the fat. You inject 100 cc, but your body might reabsorb 20% to 80% of it. It's unpredictable.
So we've covered the history, the canvas of the angiosome, the wounds, the elevator of grafts and flaps, and the tech. To wrap this up, what is the big picture here?
The big picture is that plastic surgery is the problem-solving specialty. It requires a deep knowledge of anatomy, remember the angiosomes, and a creative approach to moving that anatomy around to restore form and function. You need to know your toolkits. Know when to use a tierce, the turf versus a wolf, the rug graft. Know your flap classifications, Mathis and Nahai are your friends. And never, ever ignore a changing chronic wound. Remember the margolin ulcer.
And as we close out, there's one final thought the text alludes to that I found incredibly provocative. We've talked about autografts, using your own tissue, but the frontier is vascularized composite allotransplantation,
We were talking about face transplants, hand transplants.
using tissue from a deceased donor.
Yes!
It raises such a profound philosophical question. We said at the start that plastic surgery restores identity, but what happens when that restoration involves wearing the face of someone else? Or looking down at your hands, and they're the hands of a stranger?
It's the ultimate expression of form and function, but it comes with a lifetime of immunosuppression and complex ethics. Imagine the psychology of that. It restores function. You can hold a cup again. It restores form. You have a face. But does it restore you? Or does it create a new hybrid identity?
It's a brave new world. The text touches on it, but the ethical debates are filling volumes of their own. So, to you, the listener, go read chapter 47. Look at the diagrams of the Z-plasty. Trace the lines of the flaps. Use this audio guide as your map, but you still need to walk the territory yourself.
That's the best advice.
Thanks for diving deep with us.
Keep learning. Stay curious.
See you next time.